Peace. Welcome. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up page 223. Peace, YouTube. Welcome. Whew. Divine Rise. We made it. September 16, 2025. Here we are. Chapter 14. Retention of secretions in the tracheobronchial tree is the forerunner of atelectasis, pneumonia, and lung abscesses. This retention is frequently preventable and always treatable by bronchial hygiene regimen. The effectiveness of individual respiratory therapy modalities is combinations of techniques appears to provide an effective means of reducing the symptom complex that results from retained secretions. In the previous chapters, we have emphasized that the critical factor in bronchial hygiene is how well the therapy is applied. Bronchial hygiene is clinically effective when the patient's needs are carefully evaluated and the proper combination of respiratory therapy modalities applied. In order to accomplish a rational bronchial hygiene program, it is necessary to consider both the formulation of the evaluation of such a program. Intelligent formulation of a bronchial hygiene program necessitates 1. Defining the clinical problem. 2. Defining the therapeutic goals. And 3. Selecting the techniques to accomplish the goals. Welcome. Peace, highs, heart, love. We starting off on chapter 14. And down at the bottom now, 223. Defining the clinical problem. The respiratory care practitioner seldom comes in contact with a patient unless a physician has made the decision that respiratory care may be indicated. Thus, the initial approach becomes one of defining the clinical problem in terms of respiratory care so that a rational and intelligent consultation may be provided. This requires 2 essentials. 1. The obtaining of sufficient background information. And 2. The classification of a working diagnosis to establish the need for respiratory therapy. Page 224. All those reading along. Peace, highest heart, love, Marquise. Today is Kiara's solar return. She turned 40. Isis's mother, much love to all the September 16th out there. Peace, highest heart, love, bro. Thank you. Love you, family. Here we go. Obtaining background information. Thank you for the likes and subs. We're pushing to 5 or now 1,000 subs on this channel, reading books, where this is the peaceful place of YouTube, where we read books and learn from masters. I'm Master Uriel Riley, Master Fitness Trainer. Thank you so much for reading books, clinical books, clinical application of respiratory care. Happy Tuesday. All right. Obtaining background information. To assure that all appropriate information is obtained, 6 steps should be followed. The steps need not be carried out in exact order, but are listed here as a means of helping the respiratory care practitioner organize his or her approach. 1. Read the medical history and review the medical chart. It is essential to have an application of the length of the problem and its severity. The A review of the physician's workup can provide essential background information and provide a reasonable estimation of the patient's physical status. 2. Obtain the results of the laboratory studies appropriate to respiratory care. These studies include, but are not limited to, 1. Screening pulmonary function measurements or complete pulmonary function studies. These documents the existence of obstructive and restrictive components and quantify the general mechanical status of the pulmonary system. 2. Chest X-ray, which may document the existence and general location of acute and chronic pulmonary disease. And 3. Arterial blood gas studies, which reflect the cardiopulmonary status in general and specifically help evaluate ventilatory acid base and oxygenation status. 3. Interview and directly observe the patient to evaluate his or her ability and willingness to communicate and cooperate. This is an excellent opportunity to find out whether the patient produces sputum, coughs, has difficulty breathing, or is afraid of therapy. A history should be obtained concerning the amount, color, and consistency of the sputum. 4. Observe the patient's medical ventilatory state. This should involve 1. Observation of the ventilatory pattern. 2. Observation of the time sequences of inspiration to expiration. And 3. Use the accessory muscles of ventilation. Mechanical parameters of breathing, such as tidal volume, frequency, and vital capacity, should be measured with a portable spirometer to quantitate the observations. 5. Examine the patient's chest, including auscultation, noting the presence and location of decreased breath sounds or bronchi, rails, etc. Physical examination of the chest not only provides a respiratory care practitioner with excellent information, but also establishes a laying on of hands rapport between the therapist and patient. Very key, very key. Because of our electromagnetic field, this is masterful information. Thank you so much for likes and subs. Thank you for reading with us. We're flying through. All right, we just started chapter 14. We're here. Eyes, heart, love. 6. Evaluate personally the patient's mechanical ability to cough and breathe deeply. This usually entails the straightforward approach of asking the patient to take a maximum breath and do his or her best to cough. This is an invaluable observation and gives tremendous information concerning the patient's ability or inability to maintain bronchial hygiene. The subjective evaluation of cough effectiveness may be substantiated by the measurement of vital capacity and inspiratory capacity. See Chapter 3, which are the most valuable bedside measurements to reflect the patient's ability to breathe deeply and cough. Top of page 225. Thank you so much. It's deep, right? Peace, peace. Hi, it's Heartloop, Captain Blackbird. That's what we do, right? The light workers. We read the information, $1,000 worth of information, and we read it to the people for free here on this peaceful part of YouTube. Thank you so much. Much representation of straight honor. Thank you. Happy Tuesday, everyone. Peace. All right, the top of page 225 of Clinical Application of Respiratory Care. All right. Chapter 14. Establish need for bronchial hygiene therapy. It is incumbent upon the respiratory care practitioner to decide what disease processes are creating a need for bronchial hygiene therapy support. The essential question is, does the need for bronchial hygiene therapy stem from pulmonary or non pulmonary disease? This differentiation is essential because it determines whether the bronchial hygiene is for prophylaxis or therapeutics. Prophylactic bronchial hygiene. Prophylactic therapy is the application of techniques for prevention of inadequate bronchial hygiene. This assumes that the patient's pulmonary system is relatively free of acute disease. Some examples are neurologically diseased patients with weakened neuromuscular ability, comatose or semi-comatose patients with central nervous system disease, postoperative patients with hypoventilation, splinting, and or decreased vital capacity, and patients with trauma to the head, chest, or abdomen. Therapeutic bronchial hygiene. Therapeutic bronchial hygiene therapy is the application of techniques for the reversal of inadequate bronchial hygiene, specifically to mobilize secretions that are tending to be retained and thereby reinflate areas of absorption atelectasis and decrease the extent and longevity of infection. Peace, highest heart, love. Thank you for reading with us, Dilla. Thank you. It's part of the book lovers community. Highest heart, love. Thank you so much. Yes, we're doing it. This is, yeah, for all those aspiring to take the MCAT or be a respiratory technician, respiratory therapist. We're reading it here for free. Thank you so much. September 16th. Therapeutic bronchial hygiene. Therapeutic bronchial hygiene therapy is the application of techniques for the reversal of, and thereby longevity of infection. Since all pulmonary pathology is not accompanied by failure to adequately mobilize secretions, the therapeutic indications for bronchial hygiene therapy must be based on the patient's ability to mobilize secretions, not on the severity of the pulmonary disease. It is incumbent upon the respiratory care practitioner to consult with the physician after arriving at a working diagnosis to make sure that it is in keeping with the physician's concept of the patient's need for therapy. Defining therapeutic goals. Defining bronchial hygiene goals involves evaluation of the two primary bronchial hygiene mechanisms, the mucociliary complex and the cough. Peace, peace. Stop and smile. Thank you so much. Peace to the light workers. We're doing it. Happy September 16th. Gratitude and highest heart love. We are now at page 226. And this is so beautiful. Oh, man. Highest heart love. We love you. We love you. Yes, and we will sing it at the end, right? Helping the people remove the secretions is one of my favorite treatments at work. Just stop and smile. See, you know. You know. Thank you so much, right? Wow. Wow. And if you would like, you can put in the chat and share some of the ways that you do that while I read right here. Thank you so much. Much love. My mods are in the building. So much love. The Respitex, the healers of the world. We love you. Mucociliary malfunction usually involves the mucus blanket becoming dried or abnormally tenacious. Of course, the ciliary function may be abnormal. These circumstances will result in an abnormally discontinuous mucus blanket or in ciliary action being ineffective in mobilizing the mucus. In either case, a mucociliary complex malfunction should be improved by hydrating the mucus. Disruption of the cough. Mechanism involves one, the inability to breathe deeply. Ding! We have to put one there, right? There it is. Solutions. That's so deep. The inability to breathe deeply. Two, the glottis. Or three, the abdominal muscles. The exact component causing malfunction must be evaluated and supported. The cough mechanism may also be disrupted by airway disease, such as bronchospasm or hyperemia, mucosal congestion, or by retained secretions. The therapeutic goals are to bolster or restore functions that are believed to be inadequate. The goals of aerosol, IPPB, chest physical therapy, CPT, and SMI therapy have been discussed previously. And that's where we'll pause right here. Thank you so much for reading with us. Wow. Wow, wow, wow. Or should we keep going? Yeah, keep going. On its postural drainage and manual chest vibrations, and then guided huffing and coughing to clear the chest. Woo! Masters are always going to be mastered. Wow! Stop and smile. Thank you. See that for those in the replays, master technician right there. You see what she just said? It's the postural drainage with manual chest vibrations and then guided huffing, breath work, and coughing to clear the chest. Woo! Thank you so much for that. Stop and smile. How much love to you. I love you. I love you. Okay, table 14.1. Selection of therapeutic bronchial hygiene techniques. After the clinical abnormality and the goals of bronchial hygiene therapy are delineated, the next step is establishing a bronchial hygiene program is to choose the techniques that will best accomplish the goals. In essence, this means the application of aerosol, IPPB, and chest physical therapy, either alone or in appropriate combinations for therapeutic purposes, and SMI therapy and CPT, either alone or in appropriate combination for prophylactic therapy. Here's table 14. All right. Says outlines these goals. Note that SMI therapy is primarily a prophylactic technique. Table 14 says goals of bronchial hygiene therapy. 1. Goals of aerosol therapy. A. Aid bronchial hygiene. 1. Restore and maintain mucus blanket continuity. 2. Hydrate dried, retained secretions. 3. Promote expectoration. B. Humidify inspired gases. C. Deliver medication. 2. Goals of IPPB therapy. A. Improve and promote cough mechanism. B. Improve distribution of ventilation. C. Deliver medication. 3. Goals of chest physical therapy, CPT. A. Aid bronchial hygiene. 1. Prevent accumulation of bronchial secretions. 2. Promote mobilization of bronchial secretions. 3. Improve the cough mechanism. B. Improve efficiency and distribution of ventilation. 4. Goals of SMI therapy. A. Optimize lung inflation. 1. Prevent atelectasis. 2. Prevent accumulation of bronchial secretions. B. Optimize cough mechanism. C. Early detection of acute pulmonary disease. Yes. That's 14.1. Here we go. Thank you so much for reading with us. Man, my mods are in the building. Stop and Smile is giving us gems in the chat. All those reading with us. Clinical application of respiratory care. Let's see. Make sure. That's by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So, something I always say, people should blow bubbles in their drinks. It allows extended gas exchange. If you blow bubbles in a big jug of water, it naturally starts to vibrate bronchial secretions too. Gems. So much beautiful, beautiful gems. Stop and smile. Gratitude. I love it. Blow bubbles. I'm going to do that more now. Yes. The extended gas exchange. Wow, what a gem. Masters are going to be mastered. Thank you so much. Gratitude. Wow, that's so beautiful. That's a gem. Definitely want to highlight that. Amazing. Here we go. Page 227. At the top, aerosol therapy. When there is disruption of the mucus blanket, the addition of water directly on retained mucus results in a thinning of the secretions. Thus, by appropriately applying aerosol therapy, we hope to 1. Restore and maintain mucus blanket continuity, 2. Hydrate dried, yep, retain secretions, and 3. Promote expectoration. Systemic hydration, intravenous or gastrointestinal route, can prevent further dried and tenacious secretions from being produced, but will do little to hydrate the retained secretions already present in the airway. Coarse bronchi and expiratory wheezes throughout the chest usually mean that secretions are present in the larger airways and are located in areas where there is a good chance of depositing the aerosol. Another reliable sign of dried retained secretions is the presence of a dry and unproductive cough. The cough reflex is active because there is an irritation of the respiratory mucosa. However, the cough is unproductive because the mucus is not fluid. Whew! This is most commonly caused by inflamed pulmonary mucosa, bronchitis, or dehydration. A history of unproductive coughing does not mean that secretions are not being produced. It is more likely an indication that the secretions are being produced but not mobilized. IPPB therapy. An abnormally discontinuous mucus blanket may result in gas flow directly irritating mucosal cells. Such failure to protect mucosal cells from gas movement may result in hyperemia, edema, and ciliary malfunction. This may explain why symptoms of acute bronchitis and Crope can be so dramatically improved by the application of aerosol therapy. The delivery of vasoconstricting or bronchodilating drugs may play a significant role in decongesting the mucosa, relieving bronchospasms, and mobilizing secretions. Here we go. We'll pause right here where we reconvene with the chapter 14, clinical application of respiratory care. Happy Tuesday. We did it. Started a new chapter. Shaking it up. Thank you so much. We shake it up in the world, reading books on YouTube, live from the light here in LA. Again, shout out to all the September solar returns. Oh my God. I love Chess Physio. That is a great book, right? Thank you so much, right? And there's so many of them, but I was like thinking because I started off reading books on this channel, and the first one I did was anthropology. And thank you, love to Bethany. Oh man, Bethany, one of my great friends, is also on this channel. I showed it to her, and she was like, "Yeah, read that." And I was like, "Oh man!" And then I had to really lock in to read this, it was like, because some of the vocabulary is just so extended, high level. I wanted to make sure I get it right for the people because this is a big service, right? That we're providing as light workers, healing the people. So we want the always to be accurate. So masters are going to be mastered. Thank you so much, Stop and Smile. I love you so much, much, much love. You definitely understand. Thank you so much for the likes and subs, everyone here, reading books lovers community. We're doing it. We're doing it with the highest levels. Cheers to you. Cheers to all the healers, nurses, rest techs, physicians. We love you. Highest heart love. Mhm. So love you. I love you. I love you. Thank you so much. All right. Have a wonderful, wonderful divine rising. We did it again, right? Started a new chapter. All right. So I'll see you soon. I love you. I love you. I love you, Bubbles. See you soon. Peace, peace. Thank you so much, Stop and Smile.